era cosa que hay tienes a alguien en tu familia que es diagnosticada con una enfermedad crónica, es perder perder el miedo a lo desconocido, perder el miedo a ser criticado a veces por decir, "Ay, tengo Alzheimer, me va a empezar a olvidar las cosas". No te tienes que sentir mal, porque a veces uno, como latino, piensa que si uno le dice, es que yo nada puedo cuidar, uno piensa que está haciendo algo mal con el mal. Ser un cuidador también requiere mucha paciencia. Ser un cuidador requiere de tiempo. Ser un cuidador, yo creo que lo más importante es que requiere de amor. Y pues al principio fue difícil, pero ya después cuando encontramos la ayuda de mi mamá, pues fue un poco más fácil y te vas integrando a todo lo que te ofrecen y todo eso, entonces vas buscando más ayuda. Y así es como empiezas a encontrar otro tipo de instituciones y otro tipo de ayudas que nunca sabes si vas a necesitarlas o no, pero sabes que están. Get educated, get the knowledge about what you're dealing with and ask for the help. Like I said before, asking for help is not gonna make you that of a daughter, of a son, or a husband or a wife. It's just gonna make you better because you're asking for the help that you need to take care of that loved one that you have.
Okay, let me just share now our PowerPoint. And Berta's gonna start it off, actually.
Hola, everybody. Hello. Hola. Yeah, my name is Berta, and what you just saw was a little bit of a testimony, a personal testimony of a caregiver, who is caring for her mother. And you saw a little bit of their home, their home in the kitchen, the mom singing, you know, and talking about the role of a caregiver, her daughter, who expressed it's important to be patient, but it's when you're caregiving for our loved ones. I personally cared for my mother the last 4 years of her life. This was like 26 years ago, and she suffered from dementia, and unfortunately 26 years ago I had no clue as to any organizations or agencies that could provide support and provide me with skill building abilities to manage caring for my mother and my family and a full-time job. And it was a juggling act for sure. But I, as a Latina, I mean, my mother was, I just could not even think of placing her. And when I saw, the changes happening, because she had several high blood pressure strokes, and, her memory was affected, and then she lost her hearing. So it was very challenging, caring for someone with memory loss. Next slide. Uh-oh, are we frozen? Yeah, so we'd like to take, a moment here to acknowledge, that our project is supported by funding from the U.S. Administration for Community Living. And these are our partners. These are just some of our partners: the Alzheimer's Association, Desert Southwest Chapter, Area Agency on Aging, Region 1, Arizona Caregiver Coalition, and the Arizona Department of Economic Security, the Division of Aging and Adult Services, Arizona State University, obviously, where we're housed, Edson College of Nursing and Health Innovation, Pima Council on Aging, and of course, the Hope Network. Our goal is to improve and sustain dementia-capable systems in Arizona by filling 3 critical system gaps. We'd like to be able to identify and support persons with Down syndrome, and individuals living alone with Alzheimer's, as well as the Alzheimer's and dementia-related other dementias. We obviously want to meet and serve our underserved Latino community and persons living with Alzheimer's or other related dementias who live alone. Now, the dissemination of our educational, information and training and services, is with partners. We work with our project partners to provide education and training to our families, community providers, including first responders and community constituents. Now, we also, provide, any information and services and intervention programs, such as options like for counseling, interventions for EPIC. This is for persons living alone with Alzheimer's, and CarePro, which is for individuals with, disabilities and caregivers of individuals with disabilities, and CarePro for Latino community caregivers. Now, the Dementia Capable System project partners, we all have the goal of education, training, and programs and services. Now, evaluations are an important part of our presentations, because without the input of our audience, then we don't learn, and we don't have the honor and the opportunity to hear the voices that are very valuable and the input of our audience. So there's going to be an evaluation link and resources that will be sent to your registered email after the presentation. Now, you can complete the evaluation in English or Spanish. Also, by completing the evaluation, you can enter a raffle to win a $15 Amazon gift card. Yay, yay, woo-hoo. So, this is just a little incentive, because your time and your input, as I said, and your voice is very important to us. Now, what comes to mind, when you think about people living with dementia? And you can enter your response in the chat box. Okay, fear, confusion. For sure. Anyone else? Uncertainty, a feeling of helplessness, maybe. Oh, absolutely. Oh, yeah. Yes, definitely. Frustration. Yes. Oh, man. I can relate to that. It was very frustrating. Am I capable to take good care of my loved one? Yes. Another good point. Very good. My father just got diagnosed with it, and it is very hard to know what to do. Oh, Amy, we need to make sure you keep our phone number, you get our information, because we are here exactly for families in your situation. Feeling guilty if I'm not able to care for my loved one, oh yeah, I can relate to that. Yeah, a lot of guilt. It's like my mother, nobody knows better than I. And if I'm not on top of it and taking care of her, lots of guilt. Or am I doing the right thing? Oh yeah. Okay, let's move on, because I know we have a time, to respect here, and we want to be able to, whoops. So let's do facts and demographics here. Now, memory loss is a normal part of aging. What do you think? Is it true or false? Let's see. False, absolutely. Absolutely false. Yeah, memory loss that disrupts daily life is not a typical part of aging. Now, it may be a symptom of dementia. Now, let's face it, we all forget, like, where did I leave my keys? Where did I last see them? We're juggling work, we're juggling family, we're juggling all kinds of activities. So that's, it happens to all of us. However, if I look at the keys and I forget, what is this for? What are they for? Then that's a definite red flag. Okay, let's move on. Yeah, so what is dementia? Now, it's a neural degenerative, and you're going to have to help me here, generative disorder characterized by the deterioration of brain tissue and worsening of symptoms that ultimately lead to death. A wide range of symptoms are associated with the decline of brain functioning, severe enough to reduce a person's ability to perform everyday activities. An umbrella term, the most common types of dementia are Alzheimer's disease, vascular dementia, which is what my mother suffered with, frontal temporal deterioration, and Lewy body dementia. That is something that, most of people don't understand, that there are many types of dementia, and Alzheimer's falls under that umbrella term. Now, what is Alzheimer's disease? As we mentioned, it's under the umbrella term of dementias, the most common form of dementia, 60% of diagnosed dementias. Now, the main features of the disease found in the brain are abnormal clumps, plaques, called amyloid plaques, and tangled bundles of fibers, as you can see in the little, at the bottom right of your screen, a healthy brain versus a brain with abnormal clumps and tangled bundles of fibers. Now, these plaques and tangles cause the loss of connections between the nerve cells, and neurons transmit messages between different parts of the brain from, the brain muscles and organs in the body, causing problems with memory, thinking, mood, and behavior that results in a decline from the individual's long-standing level of ability, and it is irreversible. Now changes associated with the onset of Alzheimer's disease that disrupt daily life. These are some, of course, memory loss, particularly short-term memory. It's interesting that an individual with Alzheimer's will remember their childhood and different events 20, 30 years ago. But what happened presently is gone. They don't remember. Challenges in planning or problem solving, difficulty completing familiar tasks. They might get their toothbrush out and say, well, now what do I do? What goes next? What is the step here? Now, trouble comprehending visual images and spatial relationships, problems recalling or understanding words in speaking and writing, misplacing things and losing the ability to retrace steps, decreased or poor judgment, withdrawal from social activities, behavior changes, wandering, restlessness, sleeplessness, repeating the same question, mood and personality changes, sadness, anxieties, suspiciousness. They don't trust, we're not trusting anymore of anyone. Loss of interest in pleasant activities. Okay, now Alzheimer's disease is just memory loss. Is that what do we think about that? False. Correct. Correct. Alzheimer's is the 6th leading cause of death in the United States. It not only causes memory loss, but also loss of judgment, mood, and changes, and many more symptoms. True or false?
No, that is the answer.
Oh, sorry. Well, I'm reading and I'm having a little memory loss. No, just kidding. Heaven forbid. So Alzheimer's disease and other related dementias. These are the demographics. Some of these numbers are quite frightening, but it's information that's very important that we share. So 330 million people, 6.2 million age 65 and older have Alzheimer's disease or a related dementia. Projected to rise to nearly 13.8 million by 2060. 74% with dementia, individuals with dementia live at home. And it's the 6th leading cause of death in the United States. Family and friend caregivers provide nearly this is amazing, 257 billion in unpaid care for people. So let's move on. In 2020, the Arizona, an estimated 150,000 Arizonans were living with Alzheimer's and other related dementias. It's the fastest growing group. The fastest growing group are those over 75. The 5th leading cause of death in Arizona. And Arizona has the fastest growing rate of Alzheimer's disease in the country. Okay. And Alzheimer's disease and related dementias in the Latino community. Now note the Latino to refer, it's a large individuals who self-identify as Hispanic or Latino. Yes. Now, Latinos are a diverse group representing different countries of origin and heritages. Among top 3 of the most rapidly increasing populations in the United States. By 2060, is predicted to rise from 17% to 29%. Latinos with ADRD in the US will reach 3.5 million by 2060.
You want me to go to the next slide?
Yes, please.
Okay.
Whoops. Okay. Now, the aging Latino, 1.5 times more prone to develop ADRD than non-Hispanic whites. Now, obviously, there are risk factors, type 2 diabetes, high blood pressure, obesity, and smoking. Now, these are risk factors. 43% of dementias can be attributed to type 2 diabetes, stroke, or a combination of both. Risk of dementia is 8 times higher with a history of stroke and type 2 diabetes. Over 2 times as likely to have diabetes as non-Hispanic whites or of similar age. Next. So, and you let me know, Socorro, when you take over here. Now consider cultural and societal context. Now, the influences that can shape, the understanding of their feelings, thoughts, behaviors, we have to take into consideration, help-seeking behavior, treatment practices, views of family caregiving. Unfortunately, many of our families wait until there's a crisis, a severe example of, their loved one is lost. We've all seen those alerts, the silver alert. Many of the Latino families are that we have, received information from it's a crisis that brings them face to face with this very, very, hard disease. Now we have to uncover barriers like the language barriers, culturally insensitive services, financial constraints. Okay, next. Now, cultural beliefs and memory loss in the Latino community can be that the illnesses may not be thought of as solely physical. There's fewer distinctions are often made between physical illness and emotional disorders or social problems. Examples, we hear all the time among our Latino families, it's a normal part of aging, or it's nerves, nervios, he gets nervous and this is what happens. He forgets his grandkids because son los nervios, his nerves. A spiritual lesson for the individual or family, they may think it's got to do with their faith. Trastorno mental, mentally ill, it's a mental illness, or it's due to the poor nutrition, or possibly stress in earlier life, a tragic family situation that happened. So the Latino family characteristics, we rely more heavily on bonding or obligatory ties, like as a spouse, as a parent, as a child, relative, co-worker. We reach out, we focus greatly on, the la cultura, the value of la familia. We keep this within our, within the family. We less access to ongoing professional services and supports. We have fewer bridging or voluntary ties to licensed healthcare professionals. Perception that Latinos do not need services. Latino caregivers, majority, of course, are women with multiple roles, as I mentioned. I'm one of them. I was caring for children, minor children, and working outside of the home. More adult child and adult grandchildren are caregivers nowadays. They less formal education, lower incomes, caregiving outcomes. Females report significantly less depression, dissatisfaction with the family, support, and physical health problems. Less research conducted with males, more positive caregiving experiences, more use of religious and spiritual coping, less likely to seek services for themselves, and less burden reported.
Thanks, Berta.
Okay, so now I'm going to hand it over to my colleague, Socorro, or I know, well, you see her as Maria, but I call her Socorro, so same person.
My full first name is Maria Socorro, but I prefer Socorro, so Berta's right. Call me Socorro. Well, thank you everybody for joining us here today. Now I want to talk a little bit about the other population. As Berta started off in this presentation, we are targeting 3 underserved populations, and living alone is another one. Living alone with the Alzheimer's disease or other related dementias, for short, ADRD. So another trivia, most people with Alzheimer's disease live in nursing homes. True or false? What do you guys think? False. You are absolutely right. About 70% of more than 5 million Americans with the disease live actually at home, which leads us into talking about people who live alone with this disease. Of the 5.8 who live in the US with ADRD, 26% of them live alone. And 85% of those diagnosed also want to live at home as long as possible. So one of the things with living alone, sorry, don't know what just happened. Let me back it up, is that they will have misdiagnosis or less likely to see their own limitations because they're living alone. Most times when in the general population, those that live with somebody else or a spouse will have somebody who can see them daily and go, wait a minute, something's off, and they start to see a pattern. But if you live alone, you don't have that other person to interact with to see that. So you're at greater risk for self-neglect, malnutrition, medication errors. And of course, we're talking about not just living alone, but living alone with the disease. That's who we're talking about. Oh my goodness. So some of the challenges about living alone with ADRD is it starts this vicious cycle of communication challenges because of the way the disease progresses in the brain and what it's affecting possibly that day or in longer periods what it has already affected. Then it leads into loneliness, into withdrawal, and then it continues that cycle. So you can start to imagine the things we need daily, how that can become a challenge for those people living alone with this disease. Oh my goodness. Sorry about this, guys. So in identifying those who live alone, the challenges is, like I stated before, isolation, and they don't seek help because they may not even recognize there's changes within them, or they do but don't want to communicate because they started that cycle that I just showed previously. So us as community members, professionals, family members, identifying those who live alone and creating a system for when you know they are in the early stages or in any stage of the disease really, to help support them if they continue to live alone. And because there's going to come a point where they won't be able to live alone, or at least not safely, just due to the care that's needed and that is required when you have this disease. So what to do? Refer to healthcare and community service providers. And also the examples, you have first responders, apartment managers, even clergy to help us identify those that live alone and are living with this disease, to help support, which again goes back to supporting that dementia capable community that Arizona is really trying to build here. So with those living alone, whether you're a professional, family member, formal services or informal, you want to encourage social interaction for people living alone with this disease, engaging in gatherings with family, friends, or communities, and engaging in services that are out there like ride sharing so they don't have to drive, as well as even those food deliveries, as also using technology as a supplement, not as a substitute for social interaction. When like the pandemic, it was a great way to supplement it, but definitely not to completely substitute it, because that human one-on-one interaction is definitely very important, especially with this vulnerable population of living alone with ADRD. And continue asking for help, building that trust. So we're talking about both with family members, but also in the bigger picture of if they're in the early stages, they can, those living alone with this disease can plan it out with a trusted friend or a trusted referral of a professional organization that can figure out their living will, their medical power of attorney, how they want to be cared for, what is in their financial capabilities to cover, both insurance-wise or personal out-of-pocket. They can plan this out, because like I said, there's going to come a point where living alone is just not probably going to be an option, depending on how the disease progresses and how fast. So these things are good to identify those living alone with the disease in the early stages, because they can voice their opinion and how they want to be cared for. So let me just check the time to make sure I stay on track to give you guys the opportunity at the end to ask questions. So now I want to talk about our third population, is those living with Down syndrome and other intellectual developmental disabilities. There's not a lot of actual data on it. It's not also what makes it an underserved population, because there's just not much out there to really go by. But we're estimated about 400,000 Americans have Down syndrome. About 6,000 are born each year. So of course, with medical technology, it has extended their life expectancy, which is great. However, it comes at a greater risk for those to develop dementia at a higher rate than the general population. And you might ask yourself why. That's due to the extra chromosome that those with Down syndrome have. Is the same thing that eventually is what's found in those that develop Alzheimer's disease. That's why you'll see later in the slide the prevalence rate. It's really quite alarming. They develop dementia at a younger age than the general population, starting as late in the 30s, as opposed to for us, the general population, we start seeing it at age 65. When we do dementia awareness training and workshops, we talk about age is the biggest risk factor.
How are you? You get me spraying or getting anything? Okay, great. Thanks. I'll put the cat bowls.
Okay, so and those with IDD or intellectual developmental disabilities develop symptoms of dementia at the similar rate as the general population, but it starts to increase rapidly at a much different rate than the general population. So another little quick trivia about approximately 200 Americans younger than the age of 65 are living with early onset Alzheimer's disease. True or false? What do you guys think? Jessica says true and true. Absolutely true. So I just wanted to here differentiate. Early onset dementia refers to those individuals who were diagnosed before the age of 65. So there is a percentage of dementia that will hit the general population before 65. But early stage dementia just refers to individuals at the beginning stage of the disease, regardless of age. So you guys are on it. So this is the slide I was talking to you about. As you can see in the general population, you start to see the percentage of when you start getting affected with dementia starts at 65. But those with Down syndrome starts at age 35. But look at once you jump into the next bracket, it goes to 55% to 75% as early as age 60. So those with Down syndrome, you know, from the parents are, you know, from the moment they're born are, you know, caring for their loved one and really finding services and resources so they become as independent as they want to be or need to be. But then you can start to think, man, they hit age 35 after all that work. Maybe they're living on their own or in a group home and, you know, still are interacting with the parents, and now they're developing dementia. And then we talked about how it affects the general population. So you add that to those with Down syndrome, and then now they're needing to come back home and be cared for. So we're talking about their caregivers are their parents, which are older. So that comes with a whole nother set of worries and resources that are going to be needed, because eventually the caregiver, which are the parents, most likely will pass away before the person they're caring for. And so a lot of things need to be set up. Perhaps a sibling or other family members will need to take over the need for the person with Down syndrome or intellectual developmental disabilities and with this disease. So this slide you guys saw before, but I wanted to just kind of refresh, you know, it's quite a bit of information on there on what is associated with the onset of Alzheimer's disease. But if you are familiar at all with the population of those with Down syndrome, so you add everything that they are always encountering and their own health issues that come with Down syndrome, but now you have the disease of Alzheimer's disease on top of it. So one of the things that is unique about those with Down syndrome is the difficulty eating and safely swallowing that you need to be aware of as a caregiver, both in the informal or formal is that that needs to start to change and be monitored, because maybe they liked peanut butter before, but peanut butter now could actually be potentially dangerous, if not life-threatening, because they can't swallow safely. So these are things to think about. We're bringing you this information not so that everything seems grim and like negative, but more of the awareness of this underserved population is how can we as family members, community members, professionals, how can we be proactive on providing the best services out there for all of our populations that we've been talking about today. And also here, I wanted to highlight an increased risk of developing seizures as dementia progresses. Late onset dementia seizures affects about 80% of the population with Down syndrome. So it starts to involve different things we need to look out for and provide and be able to provide help with. Let me do a check of time just to make sure. Okay, I'm almost wrapping it up. So even with all the population, but especially with this population, early and accurate diagnosis is going to be your best defense for planning for the future of what the care is going to look like as the disease progresses, and also who's going to be in line to care in case the caregiver passes away or they become sick. You know, you have to think in terms of we as caregivers, like Berta mentioned earlier, she was a caregiver to her mother, and I was a caregiver to my I was a caregiver to my mother as well. You think you're not going to get sick, but the reality is that you also can get sick, you know, car accident, injury, or your own health issues. So you have to think bigger than just I'm caregiving for my loved one who has this disease. It's really thinking beyond that. Like, what if I get sick? What if I'm out for 3 months? Who can I count on? So it's kind of having like a fire escape or an emergency plan in case of a fire. You have that planned out where we're going to meet. Same thing with when this disease gets diagnosed. So, and then these are just some tips for a successful appointment that's really going to be helpful in getting that accurate diagnosis, but also moving forward once you are diagnosed. Obviously, we talk about this also to highlight that programs and services are needed with people with Down syndrome and Alzheimer's disease, so that you're maintaining a quality of life for as long as possible. This also applies to the general population, but being that Down syndrome is a very underserved small population that hasn't been really studied, let alone resources expanded beyond that of just Down syndrome. We're talking about Down syndrome and Alzheimer's disease. And also to support aging in place. It's really important, just like the general population, if you want to live alone as long as possible, same thing with those with Down syndrome. I won't go into this because I just want to be mindful of the time and open it up to possibly questions that you guys might have. So I'm going to stop sharing my my PowerPoint.
Thank you so
Sorry.
much, Berta.
You're welcome.
And for all the information, Socorro. So everyone, feel free to unmute yourself if you have a question. We have a few minutes left, so we can ask Berta and Socorro questions, or drop the question on the chat and I can read it to them.
Yeah, make sure that you do click on the link, please, for the evaluation. That's very important. We want to hear from you. Your input and your comments are valuable.
And this QR code is also the evaluation for the conference today. So I forgot to share that.
I also sent the link on the chat. So there's the link on the chat, or you can do the code here. It looks like we have a question here. Yeah. How can we meet someone where they're at to explain to them what they need, exams or care? My father is denying anything is wrong and refusing tests or hospitalization.
So Well, without having a one-on-one, I guess I'm going to use a personal, like with my father. If he doesn't want to go, I can't force him. But I always go the route of, well, how about we just go see the doctor to exclude that this is not what it is. Like, you know, I understand you're telling me that it's not this. Can we just have a doctor confirm that for us? And then I'll feel better. And usually my dad's like, okay, fine, let's go. That sometimes works, but like I said, without having a little more background, you definitely don't want to force or argue with the person, because that's in our workshops, one of the things when we talk about communication is that if an argument is if they're being agitated or being upset and argumentative, it's stepping back, which is hard as a caregiver, as a loved one, as a family member. But usually it's trying to figure out what is really going on, what's triggering this aggression or this questioning or this behavior, because it could actually be they're in pain and can't tell you that. So instead it comes out in form of an argument or being aggressive. I didn't quite see that comment.
It's very important that, you know, we approach it. We assume that our parents, you know, our older adults, you know, have a primary doctor or have, you know, that they've gone for, you know, whether it's, you know, physical or ongoing treatment of high blood pressure or diabetes or whatever. If we can go that route, you know, have them accept, you know, to see their primary, because it's that time of year. We've got to follow up, you know, it's checkup. And then, you know, mention to the primary doctor that there are some changes, because the best thing is for a neurologist, you know, to provide that test, those tests that will evaluate what's happening. You know, we all go to our physicals, our you know, yearly checkups or whatever for our physical care, but we never think about, you know, brain health. You know, we don't think let's go to a neurologist and let's just get an evaluation. Yes, Socorro, you were going to say something.
Karina had a good question too.
Who? Oh, Karina.
Yes, Karina, as the disease progresses, will the person with Alzheimer's suffer in any sort of form? Will there be any suffering for them?
It's different with every individual. It's different. When you meet one person with Alzheimer's, you met one person. It's all very different. Socorro?
So one of the things, again, we highlight is a little bit more on being a detective. Mood changes or certain behaviors that you see can actually be a sign of the UTI is something really quite normal that you see those with Alzheimer's disease. So UTI could be pretty bad, but won't be able to tell you. But like Berta said, it's a case by case. It's not a general across the board. Even when you read everything about for early stage, middle stage, late stage, you can see symptoms or things they describe in late stage in the early stages. So it's a guide, but yes, there is, but not the pain that I'm talking about is probably more related to the disease affecting the way to communicate to tell you that they're in pain, because maybe they have a toothache, they have a UTI, or they fell but didn't remember and now they're in pain. So I'm talking about that kind of pain, but it's not related directly because Alzheimer's disease causes the pain.
Thank you. We did have one more question here. How do we decide if a person with Alzheimer needs to get help in the home or go to a facility?
It's really an evaluation of what you are capable. Are you the only caregiver? Are you able to engage or have other family members and friends be a part of it? Because one of the things we do talk about too is that there's this hidden patient as the caregiver. There's the stress related to caregiving. Trying to do it 24/7 for a long period of time isn't, and physically, like when they start needing help to get in and out of bed or move around, you can hurt yourself, you can injure yourself, you're no longer caring for yourself. So the hidden patient is the caregiver sometimes actually passes away or gets sicker and dies before the person they're providing. So it just depends on your own resources and what you're able to do on a day by day. If you have family members that will take turns with you, but one good way to engage, like when to possibly decide that living at home isn't safe, is when it's not safe for them themselves and for you. And I'm talking about behaviors that's aggressive, where like they have access to the knives and they've tried to come at you, aggressive behavior like that. If it's a safety issue, then definitely that's definitely a time to decide that maybe living at home isn't it. But it's a case by case, and then also again, who's around for extended family and friends to help you out.
Yeah, and again, there is help. For example, the question was, how do you decide, or how can you get help at home? Remember the list of partners. You can always call the Alzheimer's Association. You can call Area Agency on Aging. You can reach out to the Caregivers Coalition. There are organizations and agencies that can provide, information on those, how can you get help in the home, or when it's time maybe to place a loved one at the later, or, whatever the need is. Every case is different. And our projects, our sessions for the caregivers, they're very, very, very valuable because, you're not alone. There are other caregivers in the same situation. And when our sessions are focused on, even though there's this diagnosis in your family, there still can be a good quality of life. And learning how to manage and how to approach, the changes that are going to take place in your loved one is very beneficial. It helps reduce the stress, the frustration, and we're providing techniques and methods of addressing those changes that are going to come. I hope that helps.
Yeah, go ahead.
I just wanted to add that in our workshops, one of the components of EPIC is that you do plan for the future, so that they're in the early stages and they have those hard discussions like, look, when I get to this point, I want you to put me in a facility because I don't want it to be a burden for you. But again, that just depends on like case by case. But I did want to add that if people have these discussions at the earlier stages and start planning, it does make it easier for when the time, not easier, it's a little less burdensome when you get to that point of making that hard decision to place them somewhere.
Awesome, thank you. I did have one more question. How can people sign up for the workshops?
They can reach out to us. I also will actually, everyone who joined us today, is there like a list of emails that maybe we can send them the link to contact us? Or if not, let me see if it's in my PowerPoint.
Okay. And for everyone that's still here, feel free to stay. Next session doesn't start until 1:45. So feel free to turn on your camera if you want to network or ask more questions. You can also leave this session and go to your next one if you're ready. Or you can also visit the virtual poster session. There's a link along with all the other links that were on the document, and you can join that as well. So either stay here and network, go to your next session, or join the virtual poster session. We'll be here till 1:45.
I did put the email in the chat, and then we'll send the link out to everyone.
Awesome, thank you.
And I just put the phone number,
Yes.
phone number 602-496-1239, so that you can call for information. If no one answers, we have a voicemail, and we do listen, every day. And so that way we can share more information, okay?
Well,
Awesome.
Thank you, everybody.
Thank you for attending.
Thank you, everyone. That was a great information, great discussion. Thank you, everyone. Make sure to complete the presentation evaluation. I dropped the link a couple times here on the chat. So very important for the planning committee so that we can continue to improve the conference in the upcoming years.
Okay.
So we can stay here till 1:45.
I really like the backgrounds you guys gave us. All right.